right. Well, welcome to Dr. Z PhD interviews. Today's special guest, I have Dr. Christine Vierregger, known as Dr. V. Another
Dr. V and Dr. Z.
That's right. Dr. V is endocrinologist in California, and she's also a trans advocate and trans supporter. Welcome to Dr. Z interviews. Thank you so much for being here. I'm so excited to interview you. You have been a colleague in the field for a number of years. You're also the #1 endocrinologist that I refer everybody that I work with to, because you just put people on the right course. Share a little bit more about yourself and where you come from.
Thank you so much. Truly an honor to be sitting across, at least virtually, from you, and an honor to be asked. And again, I'm Dr. V. Pronouns are she, her, hers, and I've been in clinical practice serving the trans, non-binary, gender diverse community in Buena Park. My clinic is in Buena Park, California. It's in Orange County since 2000. Well, clinic opened in 2013, saw my first trans patient in 2014. And well, gosh, I'm the luckiest person in the world. I've got the best job in the world because I work with the most amazing humans ever. I looked today, and since 2014, I've seen 1,333 gender diverse folks, at least. Yeah, I know. And at least an initial consultation. Not all of them are currently active patients, but it's just been my greatest fortune to find myself working with these amazing humans and calling it work. It's not work. We work hard, but as you know, the rewards are great.
It's not a work. The rewards are amazing. So before we start, and I know we're going to jump right into all of the juicy topics, all of the things people really want to hear about and are curious about, we want to put out there disclaimers that in no way is this a substitute for medical advice, and we will not be discussing what your dose of hormone should be. That's all highly individualized, and you really should speak to your doctor. So having said the disclaimer, you've been in this field obviously longer than a decade. That's a long time, and you've seen a lot of gender diverse people. To start off, what are your thoughts on consent? And when I say consent, I'm talking solely only in regards to adults. Since I work with adults, my channel is for adults. What are your thoughts on consent in terms of hormone regimens for adults?
Informed consent, I'm very grateful that in 2011, the WPATH standards of care shifted to an informed consent model. And what that speaks to is that those who have been adequately trained to diagnose gender dysphoria outside of, say, your context as a psychotherapist, but physicians and those who provide hormone therapy can diagnose and begin treatment without the patient having been to a psychotherapist previously. That was the original ruling, that one had to be in therapy for X number of weeks or months and then get a letter in order to start. That was gatekeeping at its finest. And so the informed consent model really trusts the patient. And especially when we're talking about those adults over 18, and certainly even the older they are, the more they know themselves, right? And we can trust that if they know themselves to be trans, gender diverse, non-binary, and like I said, in an appropriate consultation, meeting the criteria of gender dysphoria, then I can begin treatment even if they don't have a therapy relationships established. But I highly encourage it.
Good. I agree. I think the consent, especially the older you are, I think the informed consent model becomes very important, because I agree, the older people are, the more they know, because they've been living with gender dysphoria longer. Now, you've been in this field, like I said, longer than a decade. That's a very long time. As an endocrinologist working with gender community, what do you see are the biggest obstacles they face in regards to hormones?
And my answer to this is changing in 2021 than what it would have been previously, because and access to care, I think, is still the #1 issue in the U.S. Worldwide. Access to care is getting better. I'm no longer the only doctor with a dedicated clinic in Orange County, or even broadly Southern California, that serves gender diverse patients. But so I'm glad that there are more colleagues, providing hormone therapy. Now that is becoming rectified and more patients are able to get on hormones, I think the next challenge is actually feeling good while on hormones. And it's one thing, and there's certainly a tremendous amount of gratitude to have started hormone therapy and begun that phase of transitioning. It's another thing entirely to actually feel good. And ask any person whose hormones are out of balance. So cis women experiencing PMS or menopause, hormones out of balance can wreck us. Yes. And certainly not allow us to operate at our optimal best, feel good in our bodies. And it's okay to want to feel good in our bodies. I would even posit that most of the things we do, our primary motivation is because we want to feel better. So then the challenge becomes, is the hormone regimen that you're on, are the levels of estradiol, testosterone, progesterone, our sex hormones supportive for you as an individual? And there is no cookie cutter medicine in this particular field. It can be easy to do or fall into, but if I'm not talking to the patient, more importantly, listening to the patient, how are you feeling? And I want to get into the place where, oh my God, I'm feeling fantastic. It's not easy to get there, right? And so I think there are many, many challenges facing gender diverse patients accessing medical care and within hormone therapy. But if I can boil that down, and that of course there's a lot underneath that, but just getting to the place of feeling good while on hormones.
So this runs right into the question I was actually going to ask you, which is all about having a very individualized prescribed plan for you. And but basically what you're saying is that, yeah, anybody can prescribe a particular regimen. And it actually seems from my experience that a lot of doctors are following a particular protocol, X amount of this and X amount of that. But how you're going to adopt and modify the protocol based on individual patient, based on how they feel, based on their age, based on their health. Now that's, in my opinion, is a skill set, and that's an art. And that's what I think you actually do really well. So it is actually true, right? That the hormones are very individualized, that there is no one particular, if we're going to call it cocktail, if you will. So each individual has a completely different cocktail mix. Is that true?
That is largely true. At least that's my approach. Just because I may have seen, half a dozen trans feminine patients, this, seventh one I see may be entirely different or have a hormone level that allows her to feel good in her body. So again, I'm going to come down to, listening to the patient. How are they experiencing their hormones in their body, mind and emotions too, because hormones inform our emotional state, our mental state. And when I aim to get them feeling right as rain, and I know that's not a clinical term, but when they get there, they know it. And I tell them, you're going to know it long before me. I'm a doctor. I've got a lot of medical knowledge, and I can say, you're probably going to feel good or best in this range or at this dose. But at the end of the day, that's just my best guess.
Right.
And if that does not land properly and my dose isn't serving them well in their bodies and as they're moving through the world, then it behooves me to listen to that and adjust so that I can potentiate at least them feeling the best that they can.
So for people who are watching this, right, and not everybody has you, not everybody has another great endocrinologist that is actually listening and paying attention to how they feel and actually also looking over the blood work and knows how to read blood work. So for anybody who is watching, what are just some big kind of red flags you're on hormones, feminizing and masculinizing hormones, or just non-binary hormones regimen? And what are the biggest things to watch out for in terms of emotional states that should tell you, I should probably go see my doctor and say, this is just making me feel sluggish, fatigue, overly energized. So what would be the biggest red flags you would say?
Let's address injections. And so whether that's our transmasculine folks on testosterone or transfem on estradiol, one thing that I found some of my colleagues aren't paying quite enough attention to is a concept called half-life. And this goes for any drug that we get in our system, no matter how, whether by pill, patches, injections. But every drug has an amount of time in which the concentration in our system decreases by 50%. So knowing that, for instance, the half-life for estradiol valerate is roughly 5 days. So 4 to 5 days. So if you give an 5 milligram injection and that achieves a peak level in the serum, and I'm going to guess here, but to just keep the math easy, let's just say it achieves a peak of 300. In 4 days, that will be down to 150. In 8 days, that would be down to 75, and et cetera, et cetera. So for instance, for patients who are being prescribed 5 milligrams every 2 weeks, well, they're going to feel pretty darn fantastic for the first 3 or 4 days. And then here comes the decline. So my question to those on injections are, how do you feel in the few days after an injection? And most often the answer is, oh my God, I feel fantastic. I feel great. And I'm like, okay, how do you feel in the day or two before your injection? And I'm like, oh, wait, not great. You're not feeling as great heading into an injection as you do after. Life is way too short for that, right? So like I said, our patients have to live out there in the world. And so for 3 or 4 days, they're feeling great and they're killing it. That's fantastic. But then if there's a decline and they're slightly off, or they're very off by the time they get to days 12, 13, 14, and they kind of, essentially what's happening is they're experiencing a little bit of menopause in that 2-week period. And so, by the end of their injection cycle, they can feel actually quite lousy. So I pay a close attention to trough levels on an injections, and importantly, how they're feeling. And like I said, I just think life is way too short to be even one off on any predictable amount of time. And our bodies are very sensitive to changes in hormone levels. So if our levels are high and stay high, our bodies will be reasonably happy. Low, stay low, maybe not feel our optimum, but it's the swing and sometimes high, sometimes low, that our bodies are like, wait, what's going on? And here comes maybe emotional instability or fatigue or other symptoms of that we lose when levels aren't sustained at an adequate amount from one injection to the next throughout the injection cycle. So I kind of kid, but it's probably the hill that I'll die on. Is like, do you feel great 7 days a week? And if the answer is no, then we need to pay attention to your dose. Maybe for some, it's increasing the dose, but then we got to watch the potential symptoms on the peak level. Are you too activated? Is it a little too much? Or maybe we shorten the injection cycle and just don't get to days 12, 13, and 14. So that concept of half-life can be a very practical data point or concept in the delivery of medications that any patient can take to their doctor and say, hey doc, just based on what you know about half-life, you can predict that my levels are going to be 50%, 50% less on this particular injection cycle. My range of levels may go from very high to very low in that period of time, and I feel that. So what can we do given this medication's half-life so that I don't tank predictably every 2 weeks or at the end of every week, or as the case may be?
Okay, this is great advice and a great way to advocate for yourself as well.
It really is. And like I said, all of us doctors learned about pharmacology in medical school. The concept of half-life is something that some of us might need to dust off a little bit, or just be like, oh yeah, that's true. And you have a very valid point, right? And it's not something that really needs to set up an argument with your physician or otherwise put you contrary to them. It's a reasonable way to approach your care, and especially if you're not feeling good.
I agree. Thank you for bringing that up. I think it's really important to pay attention to that. Speaking of injections, I know that a lot of, especially trans feminine individuals watching this right now, are going to be wondering, what is the myth about injections versus oral administration versus patches? As you know, there's a lot of things going on there. In your experience, is this anecdotal myth that injections are slightly better route of administration has any level of truth to it at all?
I believe yes, and we don't have the data. I don't think we have the study. That is something that needs to be looked at and quantified and described more cleanly. And I will say that almost universally, when patients switch from pills to injections, in sometimes very vague ways, I just feel better. And then in some very more substantial ways, their feminization just kicks into high gear. I suspect, but again, this is something that needs to be elucidated with good research and data, that what the body does when oral estrogen is taken by mouth, and this even occurs when they're very diligent about buccal absorption or allowing the pills to dissolve in between their cheeks and gums, is much of that goes through what we call first pass metabolism in the liver. And estradiol is the powerhouse for feminization. And it's the level that we want to optimize because that's going to be the workhorse to get the job done. But that good estrogen is converted to a weaker estrogen called estrone. And it's not harmful for the liver. It's just the liver's job to do. So estradiol becomes estrone. And in the beginning, when I was relatively new to this, I'd have patients, I know that they're taking their meds. I know that they're very diligent about consistency, and, you know, their estradiol levels would be okay for the dose that they're on. But their feminization, I hear things like, I just feel like I'm stalling, I've plateaued, I'm not making forward progress. And I started running estrone levels. And whereas estradiol might be in the hundreds, estrone could be 1,500, 2,500. And that's just not physiological. And we don't know what high levels of estrone do long term, and what the potential consequences are. But I suspect that it's that high level of estrone. I did find a study in which if estrone is 8 times higher than estradiol in the serum, it will have a blocking effect at the receptor. So that good stuff literally doesn't have a place to land to signal for feminization. So essentially what my patients were telling me when they felt that they had plateaued on pills was, hey doc, my estrogen receptors are blocked by estrone. I'm not making forward progress and I'm not feeling so good. So that is just like you said, a virtue. It is an inherent property of oral estradiol. We can't get around that. You can improve that ratio. A lot of times keep it under that 8-to-1 by buccal absorption, but we're still going to get a preponderance of estrone. We're still going to get more estrone than estradiol. And physiologically, in cis women who aren't pregnant, estradiol there's always more estradiol than estrone, 3 to 4 times as much. So when we switch then, you can switch to patches. Even switching to patches at that point is going to be a little lateral as far as your estradiol level. But when we get anything through the skin by injection, by pellets, it's not going to go through that first pass metabolism. Estradiol will stay estradiol. We won't get a buildup of estrone. And so you get more full force of the estradiol. Patches, though, we're limited by the strongest dose. And so, you know, sometimes that can not quite get us to our therapeutic goal for estradiol. And at that point, injections are better able to do that. And that's what I think, like by some combination of achieving more optimal estradiol levels and getting estrone out of the way, there's just like, oh my God, I feel better. Wow. Yeah. Feminization. Wow. Things are taking off.
So much more research is still needed. It's unbelievable how dogmatically, I call it green, trans medical field is still quite sad, actually. Speaking about surgeries now, a lot of people are being told by their surgeons that they need to get off, whether they're on masculinizing or feminizing hormones, in order to go through the gender affirming surgery. And I now know that a lot more doctors who are very skilled and are keeping up with research out there, not asking their patients to do that. And so there seems to be this discrepancy. What are your thoughts? Do patients need to go off feminizing and masculinizing hormones?
My take is no. And the science and the data does back that up. UCSF on their website, their clinical guidelines website, has long had a paragraph of, hey, let's not take trans folks off, or those on gender affirming hormone therapy, let's not take them off in the perioperative period. And then I believe it was last year, Dr. Tang published an article basically outlining and providing the data of why that should not be requested of patients. And I get it. As on the one hand, surgeons' number one priority, let's face it, they never want to see you again. Maybe for a follow-up, one or two follow-ups in clinic, but they never want to see you in their OR again, right? One and done. Let's get this job done right. So they want to minimize any chance of a blood clot or anything bad happening. So if there was a legitimate risk for that, then, I might say, yeah, it's going to be horrible for a period of time, but the overall benefit of being off of them, it may save your life, right? Problem is that data doesn't support that. And I actually had a surgeon, particularly for transmasculine patients, where testosterone has not been shown to increase the risk of blood clots or impair wound healing. He's like, yeah, it's a theoretical risk. And I'm like, you're asking my guys to go off of testosterone, feel like crap for weeks for a theoretical risk?
Yeah.
Stop that.
And sometimes
Stop
it's
that.
longer than weeks, and sometimes it's longer than weeks. Yeah.
Oh, and like I said, if it was a true risk, that would be one thing. But consensus and the data support that it is not necessary. And so usually, what we hear on our end, how was surgery? How'd it go? Oh my God, it's great. I'm feeling, I'm swollen. It's all healing, but yay. What was the worst part? Being off of hormones.
Yeah.
Right. And at a period of time when, the body and everything should just be focused on healing from the surgery itself. If you're also dealing with hormones tanking on you, that just really complicates and makes it a lot worse than it needs to be.
And
so
psychologically too. Psychologically, just you're draining your energy. You just feel incredibly out of sorts, and dysphoria comes back, and the last thing you want to feel prior to surgery. So it's just, I agree. I think it's important. So it's okay.
So, and we'll have in the show notes a link to that article, and that can be something if a surgeon requests going off of hormones in the perioperative period, you can present that article and then hopefully open up a discussion about it.
Perfect. That's what I was going to say. So we will have an article linked below. So if you are out there and you're planning to have surgery and your surgeon is adamant, nothing wrong with printing it out and saying, hey, I came across this article. You can even say you came across this article here, and hopefully they'll keep you on your hormones. Now, shifting gears a little bit to a sex drive and maintaining sex drive and hormones. I know a lot of people that I worked with who are going on feminizing hormones, who are not interested in bottom surgery, who want to maintain their sexuality, want to maintain their sex drive. And also knows that a lot of people who have been on testosterone blockers as well as estrogen regimen have not lost their sex drive. So that's also very individualized. Some people, they still maintain that. But for people who don't, what are the options out there?
We have many. And my take is those who are, on feminizing hormones as they identify as women, healthy women have healthy sex drives and healthy sexual function. So while the experience of libido, attraction, arousal, climax, like that whole sexual response is going to change with the changing balance of hormones. And I've got questions for the grand designer of this whole plan, because female levels of testosterone between 10 and 50 and normal male levels of testosterone between 6 and 900. So at very high testosterone levels, such as those assigned male at birth experience, like that fuels their almost incessant, ever present libido and sex drive. And then of course, sexual function. So the relative difference with testosterone so low is, where'd my sex drive go? In many cases. Well, it came down into that of the female experience is where it went. And to be sure, especially those on Spiro, you can tank testosterone to 0. And any woman, cis or trans, who has single digit testosterone is going to struggle with libido and sexual response. So there is an adequacy of testosterone that needs to be present for optimal response. And it's somewhere I find usually around 25 for women, plus or minus, very individual. So, a lot of times we either achieve testosterone suppression through adequate estradiol, or maybe they've got a blocker on board. And we don't want to change those doses, especially if they're feeling good in that regard. Right. So then we've got to kind of get a little bit out of the box and maybe think creatively. So that's where perhaps Vierregger, Cialis, we can talk about other medications to help with the sexual function. And a lot of it too is just learning your body in a new way. Your body is going to respond differently. And so if we're expecting it to do what it did before gender affirming hormones, there is as much a mental shift in expectations and the experience of it kind of being all sort of new, and as patients describe, that's a mental kind of gymnasium to run through, because things are changing mentally and emotionally as much as they are physically, and getting to know yourself in this new hormonal milieu can be challenging, can be kind of exciting in the process of discovery. And importantly, if something is not functioning or you're not feeling the way that you would like to feel in regard to your sexual function, very much that you can have an open discussion with your doctor and say, hey, how do we get there? Because we can do that. You can't have the best of both worlds.
So you froze there a little bit, but the sound came through. So we're back to normal. Fine. You're fine. Yeah, sorry. That's all right. And also another option that I hear is potentially a little bit of testosterone gel if people are comfortable with that. So that's also another viable option. So in other words, there obviously options are out there. There's no need to completely lose your sex drive. And I agree, a lot of it is relearning your sexuality and just kind of shifting your paradigm around your body and the way you see your body.
To be sure.
Now, let's focus on microdosing testosterone, which is a huge subject out there. It is, I would say, probably relatively fresh subject out there. It's kind of resurfaced, I'd say, in the past 5 years and been going up. Microdosing testosterone is something that a lot of non-binary identified individuals tend to engage in when they're looking for those little subtle changes. And what can you say about the option of microdosing testosterone? Can people truly achieve subtle changes that they're seeking? And then as they achieve them, are they able to just get off testosterone once they achieve those things?
Yes, and yes. I did not appreciate, even going through medical school and living in a body that is governed by hormones, that we have latitude to explore our hormonal balance, and find levels that feel comfortable for us, much more than I gave ourselves credit for, right? And so again, it comes down to everybody's got a hormone balance where they feel fantastic in their body, and it may not be in that 10 to 50 range or 600 to 900 range. There are those who legitimately feel best in some mid-range level, and interestingly, I'm seeing some patients. Now, these are assigned female at birth. They're in their 50s or 60s, and they're just kind of cranking up they don't necessarily identify as trans non-binary, but they're cranking up their testosterone dose and landing in the 200 range and feeling freaking fantastic. And I'm like, okay, so here we are. And maybe, we just need to stay open to maybe this hormone balance isn't where I feel best. And our bodies are amazing. Hormones, by their most basic definition, are messengers. And so if we turn up the masculinizing message, then the body will start to change, and mental emotional state will change. And if we hit desired physiological outcomes and changes that individual was hoping for, then sure, we can wean them back off of testosterone, dial down the dose. There are some permanent physical changes, and then there are other changes that will come back if we dial down the dose. So as long as they're okay with that and comfortable, then sure. Yeah.
And there is no way to really gauge whether you will get those changes and how soon you're going to get them, because it seems like it's a matter of how your body metabolizes testosterone. I mean, each body is going to metabolize a hormone differently, right?
Right, right. And, we can even think back into puberty 1.0, where all of us were changing somewhere in that like between
Mhm,
11 and 18 years old. None of us changed at the same rate. Some
mhm.
got more, some got less, some didn't get any at all. And so, at the end of the day, genetics are going to determine what we get and when. And unfortunately, we can't cherry pick or say, hey, I just want facial hair. I just want my voice to drop, or I
Yeah,
just want, so we kind of start, hope for the best, and eyes wide open. There will be changes or maybe changes that occur that we just have to be prepared for
mhm.
and okay with if and when they do. And I'll tell patients, if we get in a place where things are either happening too fast or too much, reach out to me. Maybe we just slow the roll a little bit. Maybe we just slow down, whether dose, frequency, or
Mhm.
in any case, it warrants a conversation of where are you and where are we going.
Got it. And there's also microdosing estrogen as well out
Mhm.
there.
There is indeed. Now, testosterone is a really powerful hormone. And in the presence of enough testosterone, what that level is varies, but somewhere in the 2 to 300 ish range,
Mhm,
testosterone is going to be so powerful
mhm.
that it will mute any of estrogen's feminizing effects.
Got it.
So it is a little more tricky for those assigned male at birth, because we do have to suppress testosterone somewhat to
Mhm.
give estrogen some breathing room. Um, and that being the case, I do have some patients who are on pretty significant doses of both estradiol and testosterone, and that's where they feel great in their bodies. So, um, we take a case by case basis and
Mhm.
proceed according to the individual. And the important thing is we just stay in close communication.
Got it. Now, apart from microdosing testosterone or estrogen, are there any other options for non-binary identified or people who want to achieve a more androgynous look? Are there any other options out
Mhm.
there?
There are some. We don't have clinical data to really support its use in this patient population, but there are substances like SERMs, or selective estrogen receptor modulators, that activate the estrogen receptor in some
Mhm,
very specific ways, but don't confer physical changes like full dose
mhm.
estradiol would. These are kind of more of on an exploratory level that hold potential interest, to be sure. But like I said, we just don't have the data or research to fully support their use. And for instance, I don't think the Endocrine Society or other governing bodies are quite on board with these yet. We're all kind of giving a nod to them, and more research is warranted. I think you could say that about everything in trans care, because we're in many ways behind the curve on that. But so there are options out there. Talk to your doctor about them, and see their comfort level in exploring these options if they look appealing to you.
Why do you think that is? Now, we mentioned several times throughout our discussion, lack of research, lack of data.
Mhm.
Why do you think in a field that is so rapidly growing? I mean, we are on a brink of, transgender phenomenon tipping point. If we already haven't tipped, then I think it's pretty much borderline tipping and going down the hill in terms of, numbers are picking up. Why do you think there's still such a huge lack in
Mhm.
research and medical research behind endocrinology?
Um, I attended medical school between 2002 and 2006. And at the time, I was told trans people existed, I think. And there was some hand waving that if I ever needed to know anything about them, what fairy dust would fall on me or some magic wand would be waved, but I'd figure it out. So it really is lack of education.
Mhm.
A good medical school, in a very not too distant past, a good medical school spent
Mhm.
5 hours on LGBTQIA training
Unbelievable.
inclusive. You can't spend 5 hours on one of those initials and do it justice, right?
True.
So bottom line is that we in our training as physicians are shortchanged on our education on the trans experience. That is getting better, but we've got a long ways to go.
Mhm.
Doctors really like to know what we're talking about. And so if a patient comes into our office that we've never even met a trans person before, never
Mhm.
saw them in medical school, never did, like, it just was never on our radar. It can strike a real insecurity in the doctor themselves, because it's like, oh, I like to know what I'm talking about. I don't know anything about this topic. And
Mhm.
that is often where clinical experiences go sideways. So the research, though, I also remember in 2002, 2003, I believe the NIH had to tell any company that was investigating a medication that they also had to include women and children if that drug was going to be used in women and children. I mean, this has been such a male-dominated profession for so long that they were only testing drugs on men. And I'm like, hi, we're here too. Oh, and then you get into gender diverse folks and you're like, wait, what? Now it's not just men and women. We got to consider all these other people. Yeah, we do. So that I think is changing, but I'm talking in the last few years. And so I've seen graphs of, there may have been 1, 2, maybe 3 publications peer-reviewed in journals through 2011, 2012. And that curve now is very steep. And now we're getting like hundreds of published papers each year. But wow, are we behind the curve? Wow, are we way late to this party? Wow, so the best we can do is pull our data from other patient populations, cis women in HRT and menopause, prostate cancer treatments, and again, we're just way behind. But I think we've got some good explanations. Why? Not good. They're not good explanations. They explain why, and hopefully we're in a place where we're correcting that post haste.
I really, really hope so. I'm just looking forward to more research in this field. I also think it's underfunded. Who's going to fund this research? So I think funding has a lot to do with it.
For sure.
Yeah, sadly.
I've got over a dozen topics that, like, I know I'm sitting on very valuable data that just needs to be, I just need the time to study. And this is the disadvantage of being in private solo practice, that there are only so many hours in a day, and my priority is treating patients in that one-to-one encounter. And at the end of the day, whereas if I were in an academic institution, I'd have protected research time. I'm hoping it'll come, I'm intending to it, but I've had that list for years now. And anyway, so it's the difficulty, the struggle is real.
Yeah, no, I hear you. I agree. It's very hard when you're sole practitioner to also do research and to publish papers. Incredibly difficult. Hopefully, you'll be able to
do it. Though. We're going to do it. We're going to do it for sure.
Looking forward to it. Going back to the numbers, right? Do the ranges actually, is there such thing as range actually mattering in the sense of numerical number? I know a lot of people tend to chase particular number, right? Whether they're feminizing or masculinizing, there's a number that they compare themselves to in terms of their friends or their peers or people who are on hormones. And I always like to tell people it's less about the number, it's more about how particular number makes you feel. So what can you say about do ranges actually matter in terms of getting into this what considered to be a male range and a female range? Do those things really mean anything?
I'll tell patients that the numbers tell the lesser half of the story. The more important half of the story by far is how do you feel? And that's at the end of the day is the most important thing. So it is hard, if the patient comes in and said, hey, my friend is on this and that and the other thing, and I'm like, that's great if that's where your friend feels good and it's working for him, but how are you feeling? And as soon as we kind of locate, like, oh yeah, this is me, my life, my body, and my response to hormones, what other people are doing really doesn't matter at the end of the day. What it matters is, do you feel good? If you see that your friend is on, a different dose or achieving a different level, and they feel fantastic in a way that you don't, well, that's a legitimate inquiry, right? But again, we can come back. It's not a copy and paste approach.
So again, we're coming back to how you feel and how hormones make you feel. And even if your numbers in retrospect seem on a low scale, but you feel amazing and you're getting amazing results, that's all that matters.
Right.
What are your thoughts on pellets? I know that pellets are becoming more and more popular just because they're so incredibly convenient, right? You put a pellet in, you have to worry about it for, what are we talking about, 3 to 6 months, or what is the range of the pellets being effective in the body?
For estradiol pellets, aim for them to last between 4 and 6 months. And that, again, is individual and how quickly one's physiology causes those pellets to dissolve. Pellets aren't removed once inserted. They just dissolve on their own. And I wish they there's more data, again, coming back to data and evidence in this particular patient population, because I believe it is the closest we come to an internal source of estradiol. There are some arguments against the use of pellets and the difficulty in achieving appropriate levels and sustaining them. I found that with experience, and again, I've been doing this the better part of 8 years, I've got a pretty good feel, and there are calculations that we do to assess for appropriateness of dose. But the bottom line is they're inserted, they release estradiol directly into the system. They actually have been found to respond to blood flow and circadian rhythm. So it's not just a constant supply of hormone to the system, but actually the ebb and flow that more closely mimics our natural hormone production. There is some variation. I used to say that pellets hit their peak and then they just take a slow, steady slide down until we might need another set of pellets. Many pellets are blunt ended and they're inserted end to end, and then if they break apart, they fuse a bit and then they break apart. So you can get spikes in that period of time. Patients don't usually feel spikes, and for the most part, they feel much more consistent, supported. It's nice not to have to think about doing an injection or taking those pills every day. So the relief of just not having to think about it, right? Like they're loaded, see you in a couple of months, and it's just not top of mind of, did I do my injection this week, or when was the last one? When is my next one due? How do I feel? And anyway, so they're wonderful. I wish they were more accessible. Right now, estradiol pellets are not covered by insurance, and so that has to come out of pocket. And perhaps there's no surprise, testosterone pellets can be covered by insurance, but at the same time, like I said, I wish that they were more readily available. I wish more providers were comfortable using them, because as a solution for our gender diverse folks, well, if it were me, I'd be doing pellets.
Yeah, I agree. I have clients who use pellets and they love it. It's incredibly convenient. It's something that one last thing you have to think about. I have two of the biggest fears that I'd like to ask you about that tend to stem out both from the masculinizing and feminizing community. So from the masculinizing community, one of the biggest fears I hear is that if I go on testosterone, I'm going to become this raging asshole. This emotional fear that testosterone is going to turn me into this raging, outbursty individual. I like to tell people that if you're an asshole to begin with, you're going to be an asshole no matter what hormone is ranging through your body. How true is that? I would say probably at this point kind of myth that starting the testosterone treatment will suddenly make you this incredibly raging human being.
And it's interesting because yes, individual patients sometimes are concerned about that. It's more often their partners, right? Like, he's not going to turn into some asshole, as you say, right? And listen, testosterone is a powerful fuel. There's no doubt about it. In my personal opinion, it's why there are wars in the world. I mean, don't piss off someone assigned female at birth. We will wreck you, but we don't generally blow shit up either, right? So the explosive anger, the painting with a very broad brush, of course, but testosterone is a powerful fuel, and one learns to work with it. One learns how to channel that energy in constructive ways. It does create a shorter fuse, and there are things that may not bother you pre-T that once you get on T, you're like, why do they do that? And it's just something that needs to be not only managed, but worked with. And that's where exercise is fantastic, because if you sweat it out, it's less likely to come out in an unkind word or attitude. So there's a learning curve to working with testosterone, and its potential to fuel explosive anger is certainly there. What's interesting though is I had a patient with a bona fide anger issue pre-T, and we were very concerned about this. We had a lengthy discussion about and his wife, was understandably concerned as well, and so I think at every follow-up appointment, but I think it's just our very first follow-up appointment, I'm like, so how you doing? How's your anger? And he's like, what do I have to be angry about anymore? I'm on T. And I'm like,
that's a great response.
Oh, that works. That's true too. He's like, I'm right as rain. I'm chill. And the wife is like,
I
yeah,
love
he's
that.
great. He's
I
great.
love it.
Right.
What a great
So,
testament that sometimes you can have actually anger issues or any other issues, primarily because you're dealing with gender dysphoria.
of course you will, right? If you've got this incongruence, this mismatch, this static in your system of hormones out of balance, you got a lot of reasons to be angry. And then we get you supported from the inside out. And you're like, oh, no, I'm right. I'm cool.
I like how you said it. So testosterone definitely has potential for explosion, right? It definitely can create the shorter fuse. But it's not going to suddenly make you a mean person. In other words, if you are a mean individual to begin with, T or not TT just sounds like it's going to make you more likely maybe snap. Maybe, like you said, it has that shortage potential, not for everybody. But it sounds like still very different from, if you're like mean-spirited person and out there to hurt people, testosterone, not going to affect it.
No. And yeah, the way you move through the world, testosterone will augment that,
right?
For better or for worse. And I'll tell my guys too, especially if they're partnered, and I invite, as much, with consent and permission, the partners be present for our consultations. And I'll put them on notice. I'm like, listen, she does not get to be your punching bag just because you're on T and you're, irritable. Don't take it out on her, because she does not have to put up with that. So learn to work with that energy, go do some push-ups, go run around the block, but don't take it out on your partner. It's not fair to her. She's already present for you, with you in your transition. Buy her flowers and treat her like the queen that she is. And deal with your irritability somewhere else. So the potential certainly is there, and it can be tricky. It can be tricky to navigate. I love when patients at this point have therapists, because they can get those good working skills to manage their emotional responses. And then, like I said, if they're partnered, then even better if they're both in some counseling at this point.
Great advice. Now, for estrogen, the biggest fear I hear, and I actually heard some people that decided not to go on hormones because they're so afraid of this, is they're afraid they're going to gain a lot of weight with estrogen. And to be honest, in my personal experience, I seldom see that. I see that in maybe older individuals, but just by sheer force that when we're older, it tends to be harder for us to maintain and to lose weight. But I really can't say that I see across the board people just gaining a lot of weight being on estrogen. What are you experience for that?
Same, honestly. And this struggle is real. I mean, with male levels of testosterone, and if, cis guy decides he's going to go on a diet, lose some weight, all he has to do is stop drinking soda and he'll drop 10 pounds, right? So with female levels of hormones, it is easier to gain weight. It is harder to lose, but gratefully it's not impossible, right? We just have to be more mindful of how we're moving our body and what we're putting in our body. Our calorie needs are lower, and so that has to be adjusted down. But it does not have to be a given, nor should it be a given that, oh, I'm on feminizing hormones, I am going to gain weight. There will be body fat redistribution. We have thicker subcutaneous fat. We've got, the desired curves that, fat. So there can be some weight gain, but you've also got lean muscle mass loss. Bottom line is there can be 5 to 10 pound shifts in either direction when starting hormones, but over time we equilibrate usually back to baseline with a different body composition. Okay,
that's important, because a lot of people are so self-concerned and self-conscious about body.
Understandably so.
Right. And I totally see that across the board. But I think that's, in my opinion, just not worth staying off hormones when hormones can do such a huge, be incredibly beneficial to your life. For people who are watching this, and we know, you and I know that California, fortunately, tend to be a little bit more progressive. Other big states are more progressive, but there's people who are watching this who are not in progressive states, or even in parts of the country where access to care is not as accessible as is in California. And they are on hormone regimen, or they do want to make changes, and they do know that their provider doesn't know what they're doing, doesn't know what they're talking about. What is the best as a provider? And I see that a lot where people say that I'm afraid to go and advocate for my needs because I'm talking to a professional, I'm talking to authority, I'm talking to a doctor. I'm afraid their ego is going to get in the way. As a doctor yourself, and I'm sure you probably had at some point in your life, if not still, sometimes patients say, hey, this and this and this doesn't, whatnot and not. So as a doctor, what is your advice to people? How can they best broach and start the subject with the providers without really creating any kind of power struggle?
It's hard. I wish I could reliably say, hey, you could go to any doctor, have an open conversation, and really have a collaborative relationship with your medical care and medical provider. And we've all either heard the stories or personally experienced that doctors have egos, and sometimes quite large egos. And like I said before, we really like to know what we're doing. We don't like admitting when we don't know what we're doing. And so it can be really a tough situation because that clinical encounter can get turned on the patient very quickly. And, if that's your only choice to get anything and you piss that person off and now you got nothing just because you had the gall to advocate for yourself in a medical setting with a doctor who would hopefully have the maturity or at least the willingness to listen to whatever you're presenting. We know that often that'll just be like shut down and people don't like your own Google searches or whatever's, and yet, I have found that our patients are not only largely incredibly bright, but they're well resourced. And in the absence of us doing our job, they've been doing it on their own. They have become the experts in their own care.
I agree.
And these are bright individuals, and there's some really good social media groups where they're collaborating on, their research. And even though they don't have MDs behind their name, I certainly listen to them because it behooves me to do so. But that requires me a bit of humility to say, I don't know everything. And what do you know? And then, so I've had patients present data or information or requests that I'm not familiar with. I'll admit that. I'm like, okay, this is a new request for me. Let me go do my homework and let me make sure that first, we're not going to do any harm. And if this is uncharted territory, we assess the risks and possible benefits as thoroughly as we can. And then you make an informed decision and provide consent and otherwise to explore some of these options. So, that's how I roll, but I know that's not how all of my colleagues roll. And so, you can do your best, you can present the evidence as you have it, hope for the best that you have an amenable doc on the other side that's willing to have that discussion. And if that gets shut down, then there is a point where something is better than nothing, and acquiescing is a really hard. I think we die of a little death in our spirit when we're like, all right, you're right, I'm wrong, even when you've got a point, and just hope that the science continues to advance so that we can move the needle and advance care to our best interest. Because I expect that our clinical guidelines will be evolving to be more specific and, what is really the best dose, what is really the best levels, all things considered that we should be aiming for. And I don't know that we're really there yet. I hope we're not, because we are green in this field. It's not quite the Wild West that it used to be, but I don't know that we've absolutely established, based on the best sources of data, the patients we're working with, what's ultimately best for them. So until that happens, we're going to have doctors that are just going to be by the book, just going to be copy and paste because that's all that they're comfortable with. And is that better than nothing? Well, yeah. Is that as good as it will be eventually? No. I hate to do this, but good luck with that conversation. And I wish I was more hopeful, but I don't think it does any good to be overly optimistic when we all know the situation.
Yeah, it's a bittersweet. And I think it's important to remind people that if you are in a place where you actually have an opportunity to switch a doctor, it is okay to switch a doctor. There's nothing wrong with that. People switch doctors all the time. And if you have that opportunity and there's another doctor who will be receptive and will listen, it's okay to do. And I know there's a lot more, at least in US, there's a lot of places that provide now hormone regimen online. So there's online doctors and those type of resources. So that becomes much more accessible. I agree with you. So for you, as we finishing up this conversation, this amazing in-depth conversation, what are you as a provider and I know your practice is expanding and growing, what are you yourself looking forward to in trans care?
Doing that research, getting better at doing what we're doing. There's so much room for growth. There's so much room. And it's very exciting time. You know, there are not many fields in medicine that have this opportunity to kind of newly define and otherwise evolve the science in this very formative state that we're finding ourselves in. And so there's tremendous excitement to, publish this data and define these in better ways that serve the community. And I think you're right. Whether it was Laverne Cox on the cover of Time with a caption, "The Tipping Point," or, we've progressively seen things getting better, even in the midst of, a society that's not always super supportive. And yet trans people are here to stay. Gender diverse folks are here to stay. In some ways, I feel like we're seeding a revolution. I know, right? I mean, and they have existed throughout cultures and across time. So it's so needed. And we need their voices and we need their presence in our lives. My life has only been better and had an additive effect the more gender diversity there's been in the midst of it.
I agree.
So, establishing this best practices that truly affirms their care and also allows them to feel fantastic in their bodies. And once that happens, what they're able to do and potentiate out there in their worlds, it's thrilling. It really is truly thrilling. So there's a lot to look forward to. You're right. This next week, my office expansion will be complete. I will go from one. Thank you. I know.
Amazing.
It's been super exciting. But we will go from 1 exam room to 7, expanding our services and providing more like, hey, everything you need: electrolysis, hair removal, laser, voice therapy, family practice, derm stuff. So maybe it'd be more of kind of a one-stop shop. So personally, there's clear horizons and infinite possibilities. Doing, like I said, doing what we do, but better, and scaling it a little bit more. Advocacy for me. I have been so busy having to do it all in my practice that as I'm able to delegate some of the things that I do on the daily, that will open up time for me for the research, for more advocacy, perhaps be a little more visible. I don't spend any time on social media or otherwise. So I don't have time.
Me too. I hate social media.
I just don't have time for it. I'd love to be more active on Instagram and stuff, but I don't have the bandwidth. So, but there's room for improvement in that, and I'm excited about those prospects.
Doing so much on individual level. Like I said, a lot of my individual clients see you. A lot of people who reach out to me asking for information, I refer them to you just because you know what you're doing so well, and you truly listen, which I think is a key component in being a provider. You truly listen to people's needs, and you truly listen to what their goals are and where they're trying to go and how to best achieve those. Now, and I'm going to put Dr. V's information down below, and I'm going to put your website down below. For people who are watching who are outside of California, are you able to provide services to people outside of California at all?
So COVID has changed telemedicine rules in our favor. And for those needing a controlled substance like testosterone, we still need an in-person visit. So we're not going to get around that requirement. There is hope, and there's certainly advocacy on a federal level that these relaxed telemedicine rules will stay and won't revert back to being confined within state lines. But that is, yet to be determined. And there's also talk of maybe a national licensing so that, the state level limitation might be relaxed as well. So right now we can sort of take advantage of relaxed COVID restrictions with telemedicine, and then just keep an eye on the regulations and how that evolves over time. So reach out to us. We're happy to talk to you. If we can't provide you the care that you are seeking from us, then we'll hopefully be able to point you in the direction of resources more local to you. And but we'll be happy to talk to you about that.
Thank you. Thank you so much for being a part of the conversation. I'm so honored to have you on here. Always love talking to you. Always loved having you as my colleague. Thank you so much.
Thank you, Dr. Z. Coming right back at you.